it's not only ascites. Open approach, quick, patient will be sick, and these things will be the first option rather than ascites, laparoscopy, and all these things. We are not sure this patient has got ascites or not.
Yeah.
And a more important laparoscopic approach is you need to give a pneumoperitoneum, and your ventilatory function should be up, fit and well, and that's the reason why you can do it more safely.
Yeah.
And third thing is, you assume this patient had a gastric pull through, and you assume that this patient has a gastric pull through alone. So we have to come up with, again, as Amar said, wide option. I'll check whether which was done. Was it any other thing as used as a condu rather than stomach? Stomach is the commonly used condu. Is there any other options which has been used apart from stomach for some other reason? And are you going to check the stomach before using it as a condu?
Yeah, I mentioned in the OGD I'll be checking the stomach.
Okay, because I was a bit here and there. I was a bit. And when you said about the workup for this thing, it is better to include PET and diagnostic lab. I think Saqib prompted you asking for diagnostic. This is more important especially in esophagus and the stomach. Invariably, the MDT will say you to go ahead and do the diagnostic lab / PET. The question will be, I think, if I'm not wrong, the question will be, what is the role of PET when you have a distant nodes and when you have a local nodes? And the second, the other thing which I wanted to say is, when you assess this patient, when you approach this patient, they may expect you to say what is T1A and what is more than T1B. So you have the options. You have to start in a way that what is the options of management if it is a T1A and if it is more than T1A or T1B. So when you start the approach in this way, they will know that you're going to manage it endoscopically for T1A, and you're going to manage anything more than T1A as neoadjuvant plus or minus surgery. And did you mention about chemorad, exclusively chemorad? Like
actually,
definitive chemorad.
OG junction tumor. Like in none of the units that I
No. I'm saying it's not OG junction tumor. He didn't say anything. So Saqib did not give you any OG junction tumor. He came to a classification. The second thing is, it is better to mention about chemorad, definitive chemorad, or neoadjuvant plus or minus surgery. And the third thing, I observed from the radiologist during the cancer MDT, upper GI cancer MDT, is they don't use the terminology increased uptake in the PET. They used increased avidity, or it's avid. I felt that terminology. So few things, the terminology is going to make us more perfect, more towards whether we know what is happening in that unit.
But Varun, here I would disagree with you. I think that the definite chemoradiation role is emerging in squamous carcinoma.
Yeah. No, I'm sure.
And the biopsy, I have already given a biopsy. It's an adenocarcinoma.
Okay. That's fine. Okay, I didn't listen. Probably
even for a squamous cell cancer in the OG junction, I would be going for a
surgery.
Cross protocol rather than definitive chemo for a.
It's optional. It's up to you to decide about it, but you can argue with that. But
for like a mid esophageal tumor or a cervical tumor, I would be favoring like a definitive. But for a lower esophagus,
Otherwise, I think I felt that the flow was good. You took the things in the right direction. You know what to do. Knowledge-wise is okay. Things are okay. But when you come to, I think, the ethical part, you try to go down. Morally, just try to bring everyone to your side first. Discuss if things are going out of the thing. The second option is bring another consultant into the scenario of your colleague or senior colleague. And if your senior colleague and you agree, then get this thing to the MDT.
Yeah, I think instead of MDT, I should have gone for like a senior colleague or like a best interest meeting.
Yes, something that will be the best way. But anything cancer, anything progression of the cancer, yes, MDT first. If you think that this patient is in follow-up, suddenly develops some lung nodule or hemoptysis or breathlessness or something, just MDT again. But if this patient has hernia and if this patient wants the hernia to be done, then the support team around you and the support team around you rather than MDT.
Yeah.
Any difference of opinion, I'm happy to discuss. Everyone can unmute and they can speak out.
I think it was okay. I think it was good, Gohan. I think my only this thing is when he gave you the biopsy, at that point only you should mention that you will discuss the results with the patient, and then you would go with the MDT, and you will tell the patient that you are going to stage the disease. And I just felt that you jumped into surgery, the word surgery, and then the discussion went on. Oh, will you do surgery now? Do you do any other scans? Because you already knew that the patient needs a PET CT and a diagnostic lab before doing surgery. Yeah. So what I would advise is we can say, well, I would do a CT chest of the pelvis for locoregional and distant metastasis. And the patient would need also a diagnostic lab. Depending on the MDT results, I suspect you would need a PET CT or a diagnostic lab. I think if you tell like that, instead of, oh, if the CT shows this, if the CT shows that, if the CT shows this, then I would do, and then you slowly, and then, okay, then you discuss the MDT and things like that. And yeah, I think things like patient discussion and MDT, you have to stress a little bit more about MDT. Okay. And yeah, and also like in the hernia, you said, oh, I'm not going to, or you told I'm not going to operate on the patient. So instead of that, well, I will discuss best interest meeting. We'll see what I can do, and things like, obviously you are not going to refer a hernia to another consultant. So you go best interest meeting and depending on the things and all. So instead of just telling initially only, oh, I'm not, you can always say I'm skeptical, I'd be worried, so I'll discuss and all those things. So don't tell an immediate opinion, okay, I will not do. Then that's what they don't like. Yeah.
Thank you.
Can I mention the points I noted? Sorry.
Yes.
Please.
I think the focus is supposed to be more on your systematic approach at every level rather than the knowledge, like Varun mentioned about, the complications. You just categorize it. Even if you miss out the main ones, if you categorize it, they understand your approach. So I think starting from history, examination and everything, we have to just make it systematic. Of course, I have not taken this exam, but just input from everyone. And my dad was an FRCS examiner for many years, so he's been drilling me for I don't know how long.
Oh, thanks. Come back regularly. You should be available all the time.
Just to the points I noted, one was in history. So history, I usually, like Saki mentioned yesterday, either you say Socrates or something, but other than history of presenting illness, for all these malignancy cases, I usually go as I classified as history suggestive of etiology, history suggestive of complications, history suggestive of metastasis, and negative history, and then history to assess fitness. So that usually, apart from your basic points of, medications, allergies, which we don't really need to mention, these categories cover your decision making based on which, your next approach is, whether it's palliative, whether it's operative, whether it's not, that's one. Even in examination, an esophageal carcinoma is not much for examination, but I don't know whether you mentioned left supraclavicular lymph node. You mentioned about umbilicus, and of course you look for ascites in the abdomen because that's going to change your management completely. You're not even going to, your discussion is going to change from planning surgery to planning other measures. Short forms avoid as much as possible. It depends on the examiner, and like you mainly, I'm talking about the ECX that you used for chemo. If you know it, you might as well use it confidently and explain what the drugs are rather than, mention as ECX. Because you don't know if your examiner is an esophageal person or he's HPB or whatever. So in either or, you'd rather just say it out rather than the short form. And if you don't know the short form, then you're getting caught out, because if the examiner asks you what are the medications, then you better know it.
Yes.
So you might as well use it confidently. Question for me, you probably know this better, but the junctional tumors, even apart from the operation, the approach to staging also changes, isn't it? It's type 2, type 3 require a diglap, but a type 1.
Type 1 doesn't require it.
And that requires a PET CT more. So it's also the approach to staging.
For all type 1, 2, 3, I would get a PET CT, but although type 3 goes more towards like a gastric side, like the trend is like that. But still for a junctional tumor, I would always get a PET.
And Gohan, it's the most recent you are given. It is an AGCC 8, type 8. In the 7, it was the type 1 was categorized only esophageal, and 2 and 3 was gastric. But now the new guidelines is type 1 and 2 both are esophageal, and type 3 is gastric. It is the newest most.
So anyway, so those were the points.
So few points I also noticed, and please correct me if I'm wrong or right. I think that patient discussion came very late in the whole entire discussion. And I think the history is even very suggestive of, you could have raised your concern that I'm thinking that it may not be a cancer to begin with. And I think the patient discussion slightly came late. And so is the MDT as well. This was to begin with, it was an upfront look like a cancer case. So I think the MDT and patient discussion case slightly came late. Patient was informed either very late or informed very less about the disease. Even when the metastasis has occurred, the patient was informed very less. So patient discussion was one factor. When I asked the nutritional status, yes, I think you mentioned very right. But I think in a more good way, in a more standard way, you can say that I will assess nutrition on history, examination, and investigations, and some scoring system we have also. In the history, any unexplained weight loss, I will take the history, and the examination wise, BMI, muscle wasting, and on the investigation, yes, you can start with the
just to add on to this, people those who are observing, who are going to appear for part 1, Gohan, are you happy to just explain must score, because this is a thing which is used in UK in terms of nutrition and how to assess the nutritional need for the patient?
Actually, I did revise it recently, but I know one component that that for the last 7 days or something, patient is not able to intake of and weight loss of this much in the particular specific period. I have revised it recently.
The first thing is to check the BMI and assess the BMI. One, underweight, normal, overweight, very underweight, like less than 18 to 24, more than 24. First assess. The step 1 is to check the BMI. Step 2 is to check how long the patient is malnourished or not having a good diet, in terms of, is it less than 7 days, more than 7 days, or expected to be nil by mouth for more than 7 days. So that gets another one score, 2 score. Each and everything has got score 1, 2, 3, 4, 1, 2, 3. I think, if I'm not wrong. And then third step, it all goes by step. Check the BMI as first step. Check the check the nil by mouth status as second step, and then expected weight loss as the third step. If I'm not wrong, like
second step is
5% of their body weight.
First step is BMI. Second step is you ask how much was she was weighing in the last how much she was weighing in the last 3 to 6 months. Third step is, as you said, in the previous 5 days or next 5 days, how much is not going to intake, and then you do the fourth step is you do calculate everything.
Calculate, and
fifth step is 0, 1, 2.
Yeah, this is not only for the cancer pathway. This is everything. This includes everything in surgery. Even if the patient is in ITU, you perform a laparotomy and you think this patient needs more than 10 days of nil by mount, you can start the patient on TPN or any kind of enteral feed. Discuss with the dietitian what enteral feed. If this patient going to be intubated, you can start continue with you can start TPN bit earlier as well. So this is the tool which explains us to make to decide about the diet planning in prior to the malnutrition. In prior to the malnutrition, that's more important.
Okay, Varun, can you allow me to share the screen, please?
Yeah.
And the third thing is, please correct me, what is the proximal margin of the tumor? It is a 1 to 2 centimeter or still 5 centimeters advocated?
Actually, like why I told 1 to 2 centimeter is because it's like has numerous studies. Like in Japanese studies, for well differentiated tumors, they like go for 1 to 2. But for because that's the rationale behind doing like for type 2 tumor, we can operate from the stomach, from the abdomen. We can do a total gastrectomy with a margin of esophagus from the abdomen side only. But for poorly differentiated, definitely you need a 5 centimeter because there's submucosal spread and all those.
Okay. And the next thing is that the OE2 trial is a UK-based trial which advocates the use of cisplatin and fluorouracil 2 cycles in a neoadjuvant setting. The last comment is that establishment of feeding access, it didn't come in the whole discussion or very late. So
that's the thing, because you recognize that he was malnourished with albumin, and then you sort of jump to surgery, and then it shows that
actually
the nutrition. Yeah, exactly. So that's
actually I think is at that point I didn't want to mention surgery, but at some point
yeah, that's fine. It's fine. Yeah, I think this nutrition MDT patient discussion.
Yeah.
Shakib, are you happy to give me an email ID? Send me your email ID to the to my WhatsApp, please. I'll make you a co-host.
Okay. Anything else? Akshay, do you want to comment on the margin of the tumor? If margin of the resection?
I think in the recent FRCS course, what they said is in a junctional tumor, if it's a type 2 tumor, as long as you're able to put a clamp above the tumor, it's fine. That's what they told you. And if you're planning a total gastrectomy, obviously if you're buying a Iverlevis or something, then it's a 5 centimeter.
Yeah.
And also there was this ECF and FLOT. What they told us is everywhere it is FLOT.
I felt FLOT is the thing which is followed in UK.
So that's one. If you're doing ECF, then you should just have some like a evidence or something. But what they said, just don't mention magic. Magic is gone. Just use FLOT. That's what they said to us actually. So that's one. Yeah. So because it doesn't matter in which you are, say, your center or something, but I think generally it is FLOT now. So yeah.
Okay, Shakib, I'm just making you as a host. I'll try to make some changes later on.
Yes, now hosted. Good. So where was my? Okay.
Sendil, do you want to add anything?
Yeah, I will add. Meanwhile, the Sentinel is adding. This is the scoring system that we are talking.
Oh yeah, this is okay. This is the scoring system. Yeah.
Unplanned weight loss.
No, nothing to add. I'm going to. I think I'm probably going to fall asleep soon. So last night was very busy.
Low risk
clinic in the morning.
Sendil, you said that you mentioned that your dad is one of the examiner. Ask him to come.
He used to be. He retired about 4 years ago.
That doesn't matter. I think things will be good if someone joins us and screws us.
No, I don't think he's Yeah, I don't think he's going to come.
No more interested in this thing.
He's too busy.
Senthil, if you don't mind, can you just repeat what you said about the history? It was good. You talk
So
about
so apart from obviously history of presenting illness, history suggestive of etiology.
Yeah.
History to suggest any complications, and history of metastasis, negative history, and history to assess fitness.
Okay.
And your HOPI, the history of presenting illness, should give you the differential diagnosis. So
yeah,
working on that differentials, then the rest of the history to assess etiology and stuff.
Okay.
Because rarely, I mean, esophageal, then you think about this, there are specific etiologies, so obviously, like your either previous esophageal diseases or motility disorders, and then the smoking, alcohol, all those components. So similar for breast also, they say it's very important.
Yeah, even yesterday I was mentioning about this thing. Actually, any disease pattern, we can classify this as like thyroid symptoms of hypothyroidism, symptoms of pressure symptoms, symptoms of hyper or hypoparathyroidism, any symptoms of nasopharyngeal cancer. In terms of breast, check for overall history, like any malignant signs of symptoms of metastasis to liver, metastasis to bone, metastasis to lung. So instead of asking for hemoptysis, breathlessness, and all these things, just mention about the symptoms of this thing.
Sorry, Senthil, I missed two: history of presenting the pain, history of complication, history of fitness, history of metastasis.
Negative history.
Negative history. Right. So sorry.
But I love the way you threw those two hernias in there. I was like, suddenly I woke up and I was like, where did these hernias come from in this esophageal case? But also, Gohan, I was thinking, I mean, see, you mentioned about it could be possibly due to ascites and stuff. So again, one of the approaches is to think what you would do in that situation. If the patient's sitting there and I'm thinking about ascites, I would say I would do an ultrasound to confirm if there is ascites or not, rather than mentioning it could be due to. So just mention what you would do clinically. Even like these patient discussions and stuff, you would ideally, as soon as this patient you've seen in the clinic with that history, you would counsel to an extent saying, I'm thinking that this may be malignancy, in which case after the investigations, we may need to discuss it in the MDT. You do all that naturally, but at the same thing, you have to just translate it to the exam as to what you would do with the patient sitting in front of you.
Yeah.
Can we move on to the next case, short case?
Sure.
Who want to take that? Any of you? You are the guys who are appearing in the file.
Yeah, I can do. Yeah.
So, who is Akshay or Gohan?
Akshay.
So, Akshay, this is a short case, 70 male, presented otherwise fit and wealthy, presented in A&E with bleeding per rectum for 5 days. How will you assess and proceed and manage?
Okay. So my primary concern here is a possibility of a lower GI bleed, which could be a malignancy as well. I would go down and review the patient according to the CRISP protocol of A to E, ensure his new score has been assessed and all the bedside monitoring have been attached. I would take a history about the onset, duration, and progression of this bleeding. Is there any history? Is the bleeding red color or is it darkish in nature? Any history of changes with his bowel habits? Is he known to have any previous bowel disorders such as diverticulosis? Has he had any previous endoscopies as well? I would also look into his past medical history of is he on any blood thinning medications or is he on any NSAIDs or steroids? And I would like to know his past surgical history and any personal or family history of malignancies within the family. And I would also like to know about whether he's a smoker or an alcoholic and any allergies. And I would examine his, then I would move on to his examination to examine his abdomen, and also I would like to do a parectal examination, mainly looking for any evidence of hemorrhoids or any other like a polyp, if I can feel on digital rectal examination. And I would send the bloods for full blood count, urea, creatinine, and electrolytes, liver function test, renal function test, and the coagulation profile as well.
Right. So in the history, the patient just said that he had a camera test 6 months back, which was absolutely normal. He is otherwise fit and healthy and he is not on any medications. He said that he had a similar bleeding per rectum 4 months back as well, but it was a mild. He didn't seek any advice. Present in the ER, your examination findings show these.
Okay. So it shows that his shock index is actually more than 1, which means he is not acutely bleeding. He is not in a state of shock at the moment. So his abdomen is soft. It shows altered blood. I would need to, according to the ACPGB guidelines, I would do a Auckland score at this point of time to assess whether is this something that can be managed. Does it need an urgent endoscopy, or is this something that can be done as an outpatient as well? So usually, if the score is less than 0 to 8, we can the guidelines say that we can manage it as an outpatient as well. But obviously, I would speak with the patient if he has got any symptoms, or if he's still bleeding, I would admit the patient for observation, and I would also like to see his bloods as well to see if there's any anemia or any increased raised urea as well.
Okay, so you admitted this patient, and his tachycardia did not settle. He's still tachycardic of around 120. He's bit hypotensive. 100 by 80 is now blood pressure. His hemoglobin is now 88. The last hemoglobin that you have 3 months back was 132.
Okay. So I'm slightly concerned about his overall hemodynamic status, and I think he has blood as well. Does he have any cardiac disease?
No, he's saying that he's very active, very healthy, spending his retired life, enjoying the life, and all of a sudden these things has happened now.
Okay, so my next step in the marathon would be to do an upper J endoscopy as well as a flexible sigmoidoscopy at this point of time, because generally any parectal bleeding with associated such a drop in hemoglobin, there is almost 11 to 15% chance of an upper GI bleed. So do an upper GI endoscopy as well as a flexible sigmoidoscopy.
So you did an upper GI endoscopy, which was absolutely normal, and the colon was, and the colonoscopist was able to negotiate till this splenic fracture. It was normal, but it was filled of altered blood. The patient's hemoglobin next day is 75.
Okay. So I would go back and examine the patient to see if he's developed any abdominal tenderness, and is he on any medication that might be still causing the loss of blood. I think because we still don't know why he's losing hemoglobin, my next level of investigation would be to do a CT abdomen and pelvis with an IV contrast to see if he's got any blush or bleeding.
So you did a CT scan angiogram, which is in front of you.
So this is an Excel image of the CT scan of the abdomen and CT scan of the abdomen, which is showing there is a contrast within the bowel, and there is evidence of I think there is evidence of blush in the left lower side. Probably is it in the sigmoid colon? I think I would need to see the rest of the images and discuss with the radiologist.
You saw the rest of the scan and you discussed with the radiologist. The final CT scan reported as CT angio shows active contrast extravasation from tumor in distal jejunum.
Okay.
What option you will take, and what do you think it could be?
So bleeding from the distal jejunum, in terms of differential diagnosis, it could be a gist that is causing bleeding. It could be a Meckel's diverticulum, but of course it is slightly it will be a bit more proximal. It could be a small bowel tumor as well that's causing the bleeding, or angiodysplasia as well. So I think since the patient is fit and well and he's bleeding at this moment of time, and I think I would speak with the patient and explain him that we would need to take him to theater to control his bleeding at this point of time, to see as he's bleeding and his hemoglobin is a bit low. So I'd speak with the anesthetist as well as the critical care team. I would do an LRP post some scoring to assess the mortality, and my plan would be to do I would do a midline laparotomy to locate the site of bleeding as well.
Okay, so what would you do with the tumor if it is palpable on the laparotomy of the distal jejunum?
So I would resect the tumor first, and depending upon, because it is bleeding, I cannot leave it there. So I would resect the tumor, and depending on the patient's overall hemodynamic status, and before that I would ensure I would arrange some blood as well, grouping and cross matching, and as well as bloods as well. And if the tumor is mobile, completely resectable, and if the patient is hemodynamically stable, I would do a resection and a primary anastomosis of the tumor. Obviously, if there is any doubt of the resectability, then it would be quite a difficult situation. Probably I would do something like at least a palliative resection in that situation if the tumor is not mobile. And if the patient is hemodynamically unstable or anything, then I would need to do a stoma as well.
Right. So as you mentioned, you did a laparotomy, you find a localized tumor, you palpable tumor that was possibly a site of bleeding, and you did resection and anastomosis. Patient was discharged on day 5.
Yeah.
Histopathology turned out to be a neuroendocrine tumor.
Yeah.
Can you tell us about these questions? Where these tumors arise from? What is the function of neuroendocrine cells? And how would you differentiate between the benign versus malignant neuroendocrine tumors?
So the neuroendocrine tumors are basically tumors of the neural crest cells, which and the neuroendocrine tumor which of the midgut are usually called as a carcinoid tumors. The function of the neuroendocrine cells is to secrete hormones such as vasoactive amines and serotonin. Differentiation between benign and malignant is always quite difficult, and it is usually by doing we need to do a functional imaging scan, such as a somatostatic scintigraphy scan, which would show evidence of metastasis as well as the primary and metastasis. And obviously, if there's any evidence of local invasion, and also if it is a well-differentiated tumor, we can do some grading as well. If it is a poorly differentiated tumor, with a Ki-67 index of more than 3 and with the mitosis of more than 2 per high power field, these are all associated with malignant features.
Good. Okay, so that was the end. Right. Comments, please.
May I?
Yes.
Again, this is to go back to when he mentioned about the hemoglobin dropping next day. I think conceptual approach of us when we give Indian exams, I don't know where you trained, but it's the mentality change from Indian exam to UK exam is what is the next step, rather than thinking what's going on, what's diagnosis and management. Yeah. Because at 75, that hemoglobin, the first thing is they're going to ask, are you ready to transfuse blood, cross match? While you simultaneously obviously think of the next step.
Yeah.
But because we get lost in the thought of what's happening, okay, colonoscopy, nothing seen, upper GI, nothing seen. The right step is the CT angio, but the immediate thing is the resuscitation of the patient. So I think that's important. Second thing I felt is anytime you talk about the laparotomy, emergency laparotomy, I think you have to mention about morbidity, mortality scores, or at least some sort of assessment, even though agreed this patient is fit, but we need to quantify that fitness into risk. Not only for, say, assessing, obviously you're thinking it's a small bowel resection, nothing's going to happen, not much morbidity, but it's also to assess, does this patient need a critical care bed? Does it, what is, so that's what they're trying to see when you are suddenly in an emergency situation.
I did mention Nella people scoring.
Okay. Sorry. I missed that.
The blood thing. I forgot actually.
It's just, I mean, on another day on the exam, another day, another question, you might have said that first, but it's Because it's the, I think we have to concentrate on what's the next step. What you would do, you would actually, if you're standing there next to the patient, you would be like arranging blood. But in the exam, you start thinking, what.
You're right. Yeah.
Actually,
so more of,
actually, what I felt is like the flow of history is fine.
Yeah.
History, I think you got all the history. I don't think there is no issues with the history at all. Okay. You are perfect in history taking, and you said abdominal examination, things are fine. There are a few terminologies, the wordings which you can improve. Instead of saying red blood, I think bright red blood will be a better word to use there. And in history, there are few things which they collect from the patients. As a UK trainee, the history will be like, is the bleeding per rectum? If you say a history of bleeding per rectum, the question is it a flash of blood, bright red blood? Is it in tissue or is it in pan? Is it separate from the stool or is it mixed with the stool? So these are the 4 or 5 histories in bleeding PR, like fresh blood, altered blood, or bright red or altered blood, in the pan or in the tissue. Is it mixed with the stool or without the stool? Is there any slime in the stool? So these things can be bit of like what I can say, bit of spice to the wordings which can differentiate from our side. And the second thing is, you are perfectly okay with the CRISP protocol running from A to E, but you missed tranexamic acid.
But in the GI bleed, we don't give actually tranexamic acid.
Yes, tranexamic acid, any CRISP, any bleeding, any hemorrhage, ATLS, they say tranexamic acid, and this patient doesn't have any previous history of this thing. Absolutely picked up. It could be an upper GI bleed. We have to do upper GI. Second, that is an excellent thing. And the third thing is, I won't go for a flexible sigmoidoscopy. I will go for a CT angio. CT angio, mesenteric CT angio, and check where from the bleeding happens. And also, I don't think you mentioned as group and save and massive. And the first thing as a consultant or as a registrar, what I will see in the hemoglobin is, when the hemoglobin is 115, I will check the trend when the patient is in A&E. I will check, is this patient has a drop in hemoglobin from the previous hemoglobin. For example, the baseline is 140 for this patient. When you see this patient in A&E as a first time, if it is 115, definitely I won't wait for something to happen later. I'll act on it as early as possible. I won't repeat. I won't wait for tomorrow, or you say, I won't wait for the shock index or whatever, because that's a massive drop in.
Massive drop in you're right.
If it is a baseline of 140 or 130, I'll start acting on this immediately rather than waiting and watching. And tranexamic acid. And the third thing is, group and save immediately when there's a patient is on. Doesn't matter whether you do it. That's the basic thing what they'll expect you. And if there is a drop in hemoglobin, major drop in hemoglobin, I will transfuse even if the hemoglobin is normal.
Exactly. You're right.
I will transfuse the patient even if the hemoglobin is normal. If the patient has dropped 30 from
the patient,
I will transfuse the patient before I think of anything in my mind. Sigmoidoscopy, OGD, CT angio, I don't bother about all these things, because that's massive drop. Okay. And CT angio, and then I will think of any flexible sigmoidoscopy or whatever. And second thing is, when you do a CT angio, definitely I won't do a CT. I won't try to do a CT upper pelvis rather than CT angio. And the third thing, when Sakib was prompting, there is a tumor in the jejunum. Okay. The patient, that's a bit of tricky question now. are you going to manage this actively as an emergency, or are you going to transfuse the patient? You have to check whether the patient is sitting down. A tumor which is extravasating and bleeding won't continue to bleed like this when there is a drop in hemoglobin. It could be because of the hypotension, or it could be because of the hemodynamic instability. The patient is bleeding from the jejunum.
Yeah.
You never mention about the operability of the patient when the patient has got distal jejunal tumor. We have to think. I will ask more question to the radiologist, more look to the CT scan, check whether this patient is operable. Is there any distant metastasis? Is it a lymphoma which is causing the bleeding? Is it, if it is lymphoma, I'll just give one stat dose of radiation therapy that can stop the thing. I won't jump into, and if it is a melanoma, if it is a, and another thing is, if it is a jejunal tumor, a selective mesenteric embolization is going to stop the bleeding. I don't think this patient needs a surgery at all. I won't jump to surgery. I'll wait and check whether this patient can be managed conservatively with radiology guided embolization. And in spite of this, still the patient is bleeding. And if the patient is operable, you go in, check the operability. Is this a resectable tumor or not? If it is a resectable tumor, I'll make sure that the SMA is free, SMV is free, things are mobile free, and then I'll do a resection. If not, I'll do a bypass, bring the patient to the MDT, discuss, and then take it forward. That will be my approach. If there is any change in opinion, any extra opinion, I think you can, someone can comment. What do you think?
I had like this doubt, like for this patient, do you just mention it as grouping and cross match and transfusion, or you will mention massive transfusion protocol? No, right?
No, there is no massive transfusion protocol here. Okay. I'm saying I will check the baseline hemoglobin.
Yeah. I
got A&E. If there is a massive drop in hemoglobin, I will make sure that the group and save is done. Make sure that the patient is not bleeding further. I'll ask the nurses to look for the stool output, how much of blood is lost in the how much of blood is lost on a regular basis. This patient is pouring blood now, so we have to make sure that how much this patient is losing. So if it is a massive, if the patient continues to bleed, and when there is already a massive drop in hemoglobin, I'll transfuse the patient rather than just waiting and watching.
And what is the function of neuroendocrine cells? I don't know the answer for this question.
We discussed during the part 1 exams. I completely forgot. Saqib, you can come up.
Simple answer. As the name suggests, it has a both neural function and a hormonal function.
Okay.
Neural function is that the mediators that they release, they help in the motility of the bowel and perform several other functions in terms of secretions. And the endocrine functions, as Akshay has rightly mentioned, that they secrete BIP and these things they secrete. And so just mention that they have to perform two functions: neuronal function and hormonal functions.
One thing is I noticed is that on the CT there was actually we can see this hematoma. I thought it could be a hematoma, but it's a tumor. But there was something in the jejunum.
Saqib, I felt there is some blood clot in the aorta.
Yeah, I can show you.
Aorta, there was calcification. Above that, there was this hematoma. So I thought hematoma, but
allow me to share the screen. I will tell you. So few comments only. I think. I mean, recently I had a chance to review the BSc guidelines on the lower GI bleed. I think that this scenario has two parts: management of a patient according to the recent guidelines of BSc on lower GI bleed, and the second is the anatomical problem that you dealt with. Although you dealt with the resection, Varun thinks that it should have been dealt with the angiography. Difference of opinions. We can talk it later. But as far as the BSc guidelines, I think there were few good things. One was the shock index. Shock index, simple to calculate. And the BSc guidelines say that if the shock index is greater than 1, patient should go for straight away CT angiogram.
There
is no question about. BSG guidelines do recommend about the use of endoscopy, upper GI endoscopy. That is a very good point to pick up. About the tranexamic acid, BSG guidelines, recent guidelines in 2019, they have then come up with 17 recommendations. Tranexamic acid, they have said that it can be used, but it is not in their main main recommendation. And they have said that you can use the tranexamic acid if you want. And what else was stick to the BSG guidelines on lower GI bleed? Yes, about the transfusion. Transfusion trigger is actually a very vague area. In the recent guidelines, they said that if the patient has a cardiac problems, then 90 is a cutoff which you need to make sure that the patient should be on above 90 gram per liter. And for the non-cardiac, it is 70. So this is a vague area. I'm not sure that Varun is very enthusiastic in transfusion. But the BSG guidelines says the otherwise. It is the
you are right. Actually, up to 90 we can wait, but when there is a patient who's bleeding, okay, and you have to monitor how much the patient is bleeding. If the patient has dropped a massive hemoglobin, I won't wait till it reaches 90. Yes, hypotensive. Hypotension and the blood thinning helps the bleeding to stop, but if there is a massive bleed, it is not going to help, I think, if there is a massive drop. There's a difference of opinion.
So if I take your words, then the management that you were saying is that, I mean, try to do angioembolize or if lymphoma radiation, that doesn't fit into that. In that setting, if we see, then the action management was much effective. I mean, just go away and do a palpate the tumor and do a segmental resection and an
actually, I agree with the if there's a contrast blush in the tumor, there is a possibility of going with the angioembolization, but not for not radiation for a lymphoma. For a lymphoma, bleeding lymphoma, it's always surgery.
No, there is something called as enteropathy related lymphoma, enteropathy, small bowel, enteropathy related T cell lymphoma, something B cell lymphoma. In that scenario, until if the patient has got perforation, you don't operate, you just do a radiotherapy. I came across this patient once and then had a look at the literature, and they said this is more common with celiac disease. Any patient who has got celiac disease, they can end up with this thing. So better is to manage the hemorrhage, control the bleeding, put the patient in MDT, make sure that if the patient is stable, if the patient is deteriorating 24 hours, 48 hours, then crack on. Step up approach is better. Transfuse, wait for the blood loss to control. Second, CT angio. I think this is the way they do it there. CT angio.
I agree. I think it is important to mention everything. Like as you said, I would discuss with the radiologist if the tumor is resectable, is there any metastasis and all those things.
Yeah, because
your approach will change.
If you just directly jump in and then what exactly is happening,
very important.
The question will be, if you close the abdomen without doing anything, have you discussed with the radiologist about these things?
Exactly.
Will be the question. Like this becomes a purely patient mismanagement if you not discuss and if you don't.
If there any, you're right. I think we should just mention. I would consider everything. Then they may say, okay, they said it's not possible or something like that.
Just your flow of thought process.
You're right. Yeah.
Whether this can be done or that can be done or nothing more than.
And this Auckland score should be always mentioned in this case of upper GA or lower GA score.
I don't know. Can someone update me on this shock and shock score and Akshay, you can share us with your knowledge.
So the shock index is actually heart rate by blood pressure. So if it is basically heart rate should be 80 and the systolic blood pressure is generally about 110 or 120 now. So if it is heart rate by blood pressure. So if it is less than 1, there is no acute worry. And if it is more than 1, that means his patient is having tachycardia and systolic blood pressure is low, then the guidelines say you should get a CT angio as soon as possible. So if the shock index is more than
1,
Yeah, if the shock index is more than 1, it's CT angio.
Is the CT angio the first modality, or?
Yeah. If the shock index is more than 1 in a lower GA bleed, it is CT angio is the first modality.
Because you see, one shock index will be more than 1 when you have a tachycardia and a low blood pressure.
Yeah,
Then only you
exactly.
will have a shock index of greater than 1. It's
Yeah.
the heart rate divided by blood pressure, systolic blood pressure.
Yeah, systolic blood pressure. So if your shock index is less than 1, then you can do this Oakland. So you need to do this Oakland score according to the guidelines. Oakland score is the same thing, age, blood pressure, pulse rate.
Is it like Rockall score?
Exactly, yeah. The digital rectal examination, and it's all the same thing. So it is scored from 0 to 8. If it is more than 8, then you should try to get a endoscopy within the next 24 hours. Like OGD and a colonoscopy. If the score is 0 to 8, then depending on the situation, one of the recommendation is you can discharge the patient with an outpatient this thing. It is just no, I don't think anyone follows, but yeah, it is just in the guidelines or so.
Okay.
And
no, I think it's colonoscopy on the next list rather than in 24 hours.
Yeah. Colonoscopy in the next list also depends on 2 things. I think it also depends
on the Oakland score only. So if the Oakland score is more than 8, then you do a upper GI colonoscopy on the next available list. Ideally, it should be within 24 hours, but in the guidelines, it mentions on the next available list.
Okay.
Yeah, but I think calculating the shock index and the Oakland score will, help you navigate that guideline.
Yeah. Thank you.
About the malignant versus benign, yes, you are right. 3 things. I mean, the grade of the tumor, mitosis figure greater than 2, and then the Ki-67 proliferative index greater than 2%.
Yeah.
Prashant, you have joined us. I mean, do you want to add anything on this? And
No, I think Akshay did a fantastic job. I mean, fantastic, really nice.
Yeah, he unfolded.
These comments are coming from the white man himself.
Unfolded the entire scenario and went to the last question. Yeah. So should we move on to the next scenario?
Last comment: in any bleeding patient in UK, especially I think above 60, let alone 70, all these banned substances, I call them banned substances now. Doubly ensure you ask history of apixaban, rivaroxaban, all those. All the patients I see with bleeding over here, half the time they're on some really high dose of one of these banned substances, and you stop it for 24 hours, 48 hours, and the patient's fine and goes home.
I goes home.
Yeah. Okay, so next scenario, who would like to take that?
Exam guys, please.
Very small scenario, very simple.
Prashant wants to take.
Sorry?
Do you want to take?
I don't know whether I'll do well or not. Let's try. Let's try.
Would you allow me to share the screen?
No, are you not sharing? Oh, sorry. I'm sorry.
Okay. Yeah, now I'm able. Now I'm able to do that. I think for the Prashant, let's take to the scenario 5 rather than the 4. So yes, this is a very simple scenario, Prashant. 35. Sorry, not scenario 4. Scenario 4 will give to Varun.
No.
Scenario 4 is for you. Scenario 5 is for Prashant. Prashant, 35-year-old male with right upper quadrant pain, vomiting for 3 days. How will you proceed with this patient?
Okay, so this 35-year-old with right upper quadrant pain has been vomiting. So I'll assess him on the guidelines of this protocol. I'll take a focus history. And I'll ask him if he has, with regards to his pain, I'll use the Socrates method and see where his site, onset, character, radiation associated features, timing, exacerbating factors, and I will take an history with regards to his pain. And I will also ask whether he is a known case of gallstones or he's had any biliary surgery, whether he's a known case of heartburn, and whether he's on any PPIs, whether he's had any surgeries in the past for the same. I'll also ask him if he's having fever, if he's had jaundice before. With regard to the vomitus, I'll ask him what is the timing of his vomitus and what does he bring out, and whether the vomitus has any associating features or not. I'll briefly take his relevant past medical or surgical history, and then I'll progress on to examine him. I'll see whether he's dehydrated due to his vomiting. I'll see if he's jaundiced, and then I'll progress on to examine his abdomen. I'll inspect his abdomen, and will try to see if I have a Murphy sign positive, taking in mind whether he's got any acute cholecystitis or not, and see for local or generalized peritonism. And then I will proceed on to first give him some supplemental oxygen along with IV fluids, analgesia, and with regards to I'll send his basic bloods, laboratory assays, and in that I will include a full blood count, CRP, liver function test, amylase.
So let me stop here, Prashant. So,
hello?
It's breaking.
He said
Saqib,
the
I
first
think you're
time he had
breaking.
this episode, he was never known to have his pain. Is sorry.
Yeah. I think you're breaking. Can you start again?
Hello, can you hear me now?
No, you're still breaking.
Hello.
Yep. Is it me
I'm not
or
sure what's happening?
No,
Okay,
it's not you, Prashant.
you carry on.
Saqib.
Yeah. So you're
Okay.
asking me something, Saqib.
Saqib, I think his connection is not great. I think there's some issue with the connection.
Pays Wi-Fi bill.
Okay, I think he has gone out. I think it's disconnected. Shall we just go ahead and okay? Okay,
Yes.
okay.
Can you hear me?
Yeah, yes.
Okay, Prashant. Okay, Prashant.
Again, your voice is breaking.
Yeah.
Shall we go ahead with those bloods?
No, we lost the bloods also.
Yes, please.
We lost.
Sorry, can you hear me?
Yeah,
He's at temp 38. ALP was raised somewhere in the 300 or 400 range.
Yes.
Okay, there. White cell 14, CRP 68.
Yeah.
You've given him some pain relief, which partially responded.
Yeah. So he's got elevated inflammatory markers. He's got elevated total bilirubin as well as alkaline phosphatase. So this may be a case of acute cholecystitis, and in addition to IV fluids and IV antibiotics, in the light of fact that he's also febrile, I would do a basic radiological investigation in the form of an ultrasound abdomen, and I would like to see is whether he's got any gallbladder thickness surrounding pericholecystic fluid, whether he's got any gallstones, and also look if his biliary tree is dilated or not.
So yes, Prashant, he has an ultrasound which is in front of you. Can you see that?
I can see it. Yeah. So so that's an ultrasound which shows the gallbladder and the liver. I cannot see any fluid around the gallbladder, but the gallbladder wall is enhancing along with some ecogenic structures in the gallbladder, which is quite suggestive of gallstones. So I would my differential diagnosis in this case would be acute calculus cholecystitis.
Right. So yes, ultrasound, as you said, that it showed acute cholecystitis, and there was an impacted stone in the neck of gallbladder, and there was dilated intrahepatic ducts, but there was a collapsed CBD and unremarkable CBD. How would you proceed with this scenario now?
So this has complicated our diagnosis further, and this looks like it may be Mrcp with secondary and probably causing cholangitis also. In light of the fact that he's got dilated intrahepatic ducts and a collapsed common bile duct. So I would like to investigate this further by doing an Mrcp scan and confirming my diagnosis. And yeah, that's the Mrcp which has miraculously appeared. Yep. So I can see over-distended gallbladder along with dilated intrahepatic ducts, and then there is a near complete occlusion of the common bile duct distal to the origin, or distal to the insertion of the cystic duct. So this would be a type, I would say a type 3, because I cannot see type 3 Mrcp, because I cannot see any air or obvious fistula of the Mrcp. But then I would like to discuss this with an experienced HPV radiologist and confirm my suspicions.
Okay, what are the different types of this syndrome? And
so Mrcp would be classified as 1, 2, 3, 4, and 5. One Mrcp 1 would be just an extrinsic extrinsic compression of the CBD with just an extrinsic compression with no pressure compression, complete compression of the CBD. Mrcp 2 would be less than 1/3 of the compression of the CBD. Mrcp 2 would be up to 2/3, and Mrcp 3 would be near complete obstruction of the common bile duct. Mrcp 4 would be along with cholecystosis.
So you discussed with so Prashant, you discussed with the radiologist who is an expert in HPV diseases. He says that this is the type 1 Mrcp syndrome. How will you definitely manage this syndrome? Type 1.
Type 1 Mrcp syndrome would be easier to manage with in respect to the other severe types of Mrcp syndrome. In this case, I would like to consent and talk to this patient and tell him these findings and tell him that he would possibly need a laparoscopic cholecystectomy with an on-table cholangiogram. I would proceed on to explain him the procedure, as well as consent him and of course explain him about the risk of a laparoscopic cholecystectomy. And then after I've obtained his consent, I would go ahead and book him for a laparoscopic cholecystectomy with an on-table cholangiogram after seeing his fitness.
Good, that's it. Comments, critique?
Just two things I wanted to say. One was I didn't listen to the part that whether he mentioned antibiotics consider white cell count and everything. Second was,
I think I mentioned that in when he showed me the blood results.
Okay, and second is for type 1 Mrcp. Another thing is subtotal cholecystectomy. You could have just mentioned is if it's a frozen callos. Like they typically tell the subtotal, so you went for a laparoscopic total cholecystectomy.
Yeah, the thing is, I didn't want to dig my grave there by mentioning subtotal cholecystectomy. Obviously, that is one of the thing, but then I'm venturing into much more dangerous territory. So if I would actually wait for the examiner to ask me, what if you cannot do it? Then I would have said subtotal cholecystectomy.
Yeah, go ahead.
Someone ought to do so.
Sandhya. The only criticism would be that at the point when you see the deranged LFTs, I would say acute cholecystitis / possible either biliary stones or a complicated cholecystitis with Mrcp, not just commit to only acute cholecystitis.
Yeah, I agree.
And I mean, that's the only thing, because also the ultrasound showed dilated intrahepatic ducts, whether it's a past stone. We don't have an ALT, so whether it's just a transaminitis picture or whether it is an obstructive pattern, obviously the trend and everything will matter.
Yeah.
And Saqib, that MRCP looks highly dangerous and very unlikely to be type 1.
I don't think it is a type 1, by the way.
I almost looks like a complete cutoff and stricture of the bile duct.
Yeah, but actually, the images are not from the real patients. It's mostly images I've got from the Google.
Guys, I just wanted to mention this. There is a website called Radiopedia. Check those Radiopedia. You have plenty of images of different things. Okay, just go ahead and do a MCQs for any kind of learning. Go to radiopedia.org if I'm not wrong. Just Google it. You will get plenty of images. Don't Google the images. You will get the images saying that this is CBD, this is gallbladder. What is that? This is with an arrow mark. So in Radiopedia, you will get MCQs or you will get the images without anything. You will have a report of this thing after the few slides. You will get learned a lot.
Yeah, can I just say in reply to Yasir, I completely agree with you about relieving the obstruction. But when it comes to a type 1, you can do, rather than relieve the obstruction with ERCP, you can actually do a laparoscopic cholecystectomy as a single stage.
Yeah, you are right.
If it's a type 1.
Yeah, that would relieve the obstruction, and you're already treating the cholangitis with, whatever it's worth, by IV antibiotics, and then you list this patient immediately for your laparoscopic cholecystectomy, because I think that's the guidelines for this, because the guidelines is you do the laparoscopy for a hot gallbladder, you do it in the same hospital admission episode.
But here the question also arises. Sorry, here the question arises that most of the hospitals do not go in for such kind of hot gallbladder, especially.
Yeah, I've actually.
And if the question is, what is your practice? And the question is,
there's a trial going on, and we at Trial Free were
they've finished the trial
all
also.
these cholecystitis for hot gallbladder. So we
Sunflower trial,
all the patients.
Yeah. So the guidelines is in the same hospital admission. The reality is different, but if again, that's digging your own grave if you start talking
The
about
reality is that MRCP comes, the patient is settled down.
Yeah, exactly.
and especially the question is, what is your practice in your center? And if this is and it is such kind of question, how would you say that? And you belong to a center who doesn't practice in hot gallbladder.
Yeah.
Yeah, I think
cholecystitis, you always have to mention, like, if within 7 days go for a cholecystectomy.
Yeah.
But I think it is just I think Prashant, you did well with regard to surgery. I think it's always better to give some options. I'm aware that one of the options is a gallbladder, one of the options is this thing, or just drainage of this thing. But in this situation, like you sort of weigh the risk and benefits, so that the examiners know that you are aware of the other options as well.
Yeah. That's, I agree with you, because then the thing of the Montgomery rule also comes into
exactly.
You didn't give any other options. I agree.
Prashant, what about the amylase level and terms of
I didn't mention that we'll send the amylase levels also.
Okay.
But then amylase level would be elevated in cholecystitis also, but it wouldn't be that elevated compared to pancreatitis.
Fantastic. I don't have any objection at all. Like it went perfectly fine, well.
No, come on, guys. This is cholecystitis. You gave me the easiest one, and you're telling me I did well. I mean, if I didn't do well on this, then I'll defer my exam.
It's just warm up.
I think you should have mentioned the sepsis 6 when you found out that.
Yeah, that's important. Yeah, I agree.
Okay, so Prashant, if you want to take a difficult one, I have a scenario 4. Which
No.
Who wants to take the scenario 4?
I'll take.
One is the last one.
Yeah.
Can I take?
Senthil, do you want to take?
Oh my God! I was just going to say I should have signed out and gone.
Who said yes? Who said yes? Who said yes? Whoever is.
Said yes.
Go ahead.
Sakib, just a second. There is someone who texted me that they are not able to talk or something.
The audio, yeah, sir.
Yeah, who's that actually?
Unmute then.
Yeah, unmute. Let us. Yasir Kelani. Just a second. I'm going to unmute Yasir. If you want, you can speak. Yasir. Sorry. What's happening? Oh yeah, Sakib, you have to do it. You are the host now.
Okay, so I have done that.
Just go to the participants and Yasir Kelani.
Okay. So the last scenario will be Akshay will be doing, or Gohan? Who is doing that?
Gohan. Able to hear me?
Yeah.
Yes.
Asked to start.
Okay, he's not able to can't speak right now. That's okay. Go ahead next.
Okay, so Gohan, it's your scenario?
Yeah.
Okay, so Gohan, this is the scenario 4, which is slightly challenging, but not much. 65-year-old female, known case of FA, presented with mesenteric catastrophe, as she was on apixaban, and you did an extensive small bowel resection. The only bowel that is left behind is 30 centimeters small bowel up till the jejunostomy that you made, and the 15 centimeter terminal ileum is left behind. She is recovering well from the surgery, and on day 5, she is asking about what operation did you do and when will I recover? How would you explain these findings and answer this question of the patient?
Yeah. So from the history, I came to know that she had a acute SMA syndrome, acute superior mesenteric artery occlusion, and had undergone a massive small bowel resection. And she has a jejunostomy, and I assume that it's a high volume jejunostomy. So, but the question to me is how I communicate with the patient. So I will explain to her about the surgical findings and the reason for she had the atrial fibrillation, and probably she had developed a clot in her blood, and the clot had obstructed her superior mesenteric artery, and due to that, vascularity of the bowel was lost. And so we had gone in with an emergency surgery, and we found that her bowel was not viable, and we had resected this length of small bowel. So almost like up to 90%, more than 90% of her small bowel has been resected. So I would like to have this conversation with the patient, with the clinical nurse specialist, and with the nutritionist as well. So I would be explaining to her that since most of her small bowel is lost, she'll be having high output volume from her jejunostomy, and she'll be having a stoma bag and with a high volume. So we'll be giving medications to control the output. And so first we have to optimize her nutrition. So the dietitian will be working closely with her and to building up her nutrition. And once she is out of this acute phase, she'll be going on blood thinners as well. I think she's previously on blood thinners as well. So she'll be going on blood thinners. And once she's out of this acute phase, we'll be re-imaging her with a aim to join her bowel back. But have the consequence of having a short bowel is that her nutrition is compromised. We have to work a lot on her nutrition. Even if we join her bowel back, there is this is a case of intestinal failure. So her bowel will slowly start recovering. It will start adapting, and the small bowel will start absorbing more. So she might gradually get her nutritional status back. But in the initial management, she'll be going on medications, probably TPN, and so this I would be explaining to her. But regarding her management, I would be starting her on proton pump inhibitors, octreotide, loperamide, and starting her initially on TPN, and then all the measures to decrease her stoma output, monitor her electrolytes, and monitor her LFTs if she's on TPN. So bloods wise, I would like to see her as I told, electrolytes, INR if she's been started on blood thinners, and the dietitian opinion for regarding how to manage her nutrition. And I'll be having a multidisciplinary team meeting with the gastroenterologist, nutritionist, myself, and the stoma. She'll be seen by a stoma nurse as well for managing her stoma. So all the people will have a multidisciplinary team meeting with the family as well, and we'll be aiming to deal with this complex patient.
Good. Okay, so Gohan, the next question for you is, what fluids, electrolytes, nutrition, and metabolic deficiencies you are anticipating, and how would you manage this patient? You have mostly partly replied, but what are the nutritional and metabolic problems that this patient can have?
So since it's a very proximal jejunostomy, almost giving her oral intake might her digestion is almost like completely lost now. So orally, although we can give her orally, but it wouldn't be enough for her. So I would start her on TPN. I would ask for a PICC line and start her on TPN, because she'll be needing the TPN for a while before we can plan on any other management for her. So coming on to the fluid and electrolytes, since it's a proximal jejunostomy, she'll be having low sodium, potassium, and water loss as well. All these needs to be managed, but since I'm starting on TPN, see her LFTs and other micronutrition deficiencies as well. So I'll be managing everything here.
What is the definition of intestinal failure, and what are the common causes of intestinal failure?
Intestinal failure is inability of the patient has a short length of bowel. I think it's less than 60 centimeter of small bowel. I'm not exactly sure, but coming on to the causes, common causes of intestinal failure, it's usually superior mesenteric artery occlusion. We can characterize into inflammatory causes or neoplastic causes or traumatic. So coming on to the inflammatory bowel disease sometimes may lead to intestinal failure, and vascular causes, the superior mesenteric artery syndrome, and traumatic trauma and loss of intestine, and sometimes radiation induced intestinal failure is there as well. And yeah, these are the common causes I would like to mention.
Okay. Will you plan to anastomose the bowel?
Yes, I would like plan to anastomose the bowel. So optimizing her nutrition, and once she's out of the acute phase, manage her anticoagulation, do a complete workup for her. Although she has atrial fibrillation, I'll do other workup for hypocoagulable states as well. And I'll plan for joining the bowel in like 2 to 3 months. I would plan on joining back the bowel. Before that, I'll be imaging her, the CT with IV contrast and oral and rectal contrast as well, and doing an imaging.
Okay. When would you refer this patient to national intestinal failure centers?
Yeah. If this patient's nutritional needs are still not met, and the patient is having like persistent diarrhea with acute weight loss, and I feel that I can no more help with this patient, then I'd be referring her to the intestinal failure centers. Yeah.
Okay. That was the end.
Yeah. Who wants to? Sandil, do you want to comment anything?
Yeah. Go on. I think in this case, I don't know whether it's because my GC is dropping, but I think intestinal failure you have to recognize as considered now in UK as literally as a subspecialty, and your questions are going to be the phases of intestinal failure, when you're going to reanastomose, and eventually do you need a small bowel transplant. And I think you need to cut to the chase, say involving, this is a multidisciplinary team that has to involve the stoma nurse, the dietitians, and you have to do a referral to the intestinal failure center. It's not for transfer, it is for opinion. Either you're a specialist and you're managing it, or you have to refer and get an opinion saying, I've had an emergency, I've had to resect this much of the bowel, this is the current status of the patient, are you happy with the way things are going? Does she need transfer to a referral center? I think those have to be early in this case, and not when you say, when I can't help anymore, because you're playing catch up in this disease, unfortunately, and you know, every single day you're catching up with the electrolyte losses, volume losses, and there's a very clear cut protocol system and everything for the intestinal failure units in terms of their daily management, and then when they reach the second phase, then how the management changes, and when you can anastomose, and when they require, say, further help for a transplant.
Prashant and Akshay?
Yeah, I agree with Senthil with everything. I think so just to start, Guhan, so yeah, first of all, it's a very difficult scenario. There is no doubt. Just to start, the question was when. So the patient is asking when will I recover? So the first, so taking into account it's a 6-minute scenario, almost 1 to 2 minutes, almost 1 minute, you are just just telling what is the question again. Like you are just paraphrasing it.
Yeah.
Instead of that, you can always say, I think when there is a colon left, the minimum length of bowel you need is 50 centimeters. And so this is almost less than the borderline. So you can say, well, this patient has got a severe short bowel syndrome, and it is likely that she would require a home TPN. So it's a very difficult scenario. And then you'll take the dietitians, nutritionists, everything. And and as Senthil said, you will refer the intestinal failure. And then you try and I think you need to just discuss in a layman's term when the patient is asking when will I recover. You can just this thing, but very early involvement of intestinal failure centers is important.
Yeah. Prashant?
Yeah.
Prashant, you are muted. Unmute yourself, Prashant.
Sorry. I'm just saying, I think, correct me if I'm wrong here, but I think the best answer to that patient when she says, when will I recover, is to give a non-committal answer and actually to tell her that it's possible that you may not recover from the short bowel syndrome unless you receive specialist care, because that again goes on to the types of intestinal failure. And I just read it because I didn't know anything about it while you were talking. I think that there are 3 types: type 1, type 2, and type 3, which is according to the St. Mark's criteria. And this falls in type 3, which is long term, which is short bowel syndrome. So I think the answer to that would be non-committal, and I think we'll have to discuss that with the intestinal failure unit, and we'll take it from there. I think.
Go ahead. I think Prashant picked it up. Actually, what I felt is like my approach to this patient will be like I'll have a frank discussion about what happened in the theater rather than telling the causes like SMA occlusion or SMB occlusion. We don't know whether it is SMA occlusion or SMB occlusion. This I will just mention that we removed this much of bowel and this much of bowel is left out. So it means there is some kind of absorption problem, which will be a long-lasting problem. And the second thing is, I was just correct me, guys, if I'm not wrong. I thought of short bowel syndrome as a first thing rather than intestinal failure. Intestinal failure can be anything. Even it can be because of Crohn's disease, can be because of ulcerative colitis, it can be because of multiple strictures in the Crohn's, it can be something else as well. But this is a classical short bowel syndrome rather than intestinal failure.
So intestinal failure is a broad term. Intestinal failure is a condition where the bowel is not good enough to
absorb. There is
good enough to achieve absorption to maintain a normal life, and you need intravenous either nutrition or fluid resuscitation. So intestinal failure. So it comes everything, and type 1 is just self-limiting, and type 2 is all this intracutar fistula, and type 3 is short bowel syndrome. It's fine. Intestinal failure is, I think, should be.
As Akshay has mentioned, that intestinal failure is a condition when you don't have enough either anatomical or functional bowel left behind to maintain fluid, electrolytes, and more importantly, we always forget nutritional homeostasis. So that includes all the salt electrolytes as well as carbohydrates, lipids, and amino acids, and these all are included. When you don't have enough anatomical or a functional bowel, and depending upon that, you can have an loss of anatomical bowel because of this catastrophic surgery, trauma, and the functional loss could be you have a bowel left behind, but you have an enterocutaneous fistula, which is very proximal. So you don't have enough functional bowel, although the rest of the bowel is very much functional, but it is bypassed because of it. And it can be because of the intrinsic disease of the bowel, which leads to the bowel, which decreases the bowel absorptive capacity, like a celiac disease, like inflammatory bowel disease, like radiation enteritis. So these are all the conditions when you have
so this one can we mention it as short bowel rather than an intestinal failure?
So no. So short bowel, yes, it's an anatomical problem. If you say that it's an intestinal failure secondary to the short bowel, or I'm suspecting an intestinal failure secondary to the short bowel, then it will be a right answer.
Something.
So short bowel is a subset of intestinal failure. So it comes in type 3 of intestinal failure. So type 1 is self-limiting, which has got post-op ileus and inflammation. Type 2 is prolonged, which has got GI complication, enterocutaneous fistula or abdominal sepsis. And type 3 is long-term, which includes short bowel syndrome, chronic obstruction, or a motility disorder.
Okay, so the second thing I wanted to say is regarding the recovery and all this thing. The question started. Sakib, are you happy to go to the first slide, please? So the question is 15 centimeter of terminal ileum is left, 30 centimeters. So the question starts from what are you going to explain to the patient and what went well. So regarding the recovery, I'll just openly say that you are not going to recover sooner. It will take years or months. That's my answer. That will be my answer. No ifs and buts. Straight away, this is not going to be you are not going to get discharged like this. You will need a long-term treatment, and you may be referred to a specialist center for your nutrition problem. You may not even recover because you are 65 years old with the previous comorbids, so this is an open discussion. The intestinal failure, it doesn't mean that all the patients recovers out of intestinal failure or short bowel. I don't have statistics saying that how many patients are on long-term TPN, home TPN at the age of 65. I don't think it will be more than 50. Yeah, what do you think, guys? Sindhil, Prashant, Sakib?
Yeah, completely agree.
Yeah, agree.
I think there's something this discussion should have happened before we take the patient to theater.
No. That is what, when it comes to recovery, my first approach will be say the patient, you may not recover. You may not recover. You may recover, and if you recover, you may be in a long-term TPN, and you may recover for a year, and then you may fail again, and you may need a referral to a specialist center. So that will be my approach.
Yeah.
The only thing from this, the only emphasis from this scenario I would like to raise is that whenever the intestinal failure comes in, the only things that comes in mind is the significant amount of bowel resection or an EC fistula. But we forget that even the ileus, as Prashant has said, that it also can cause intestinal failure. A post-op ileus and pseudocolic obstruction, Ugleev syndromes, can also cause intestinal failure. Anything, whenever any condition when you don't have enough functional and anatomical bowel that leads to these unable to maintain the equilibrium among these fluids, electrolytes, and nutrition, you call it an intestinal failure.
Okay. And the next thing is regarding. Can you go to the previous slide, Sakib? So you were saying about Gohan, just to update. There is a separate chapter in colorectal, companion colorectal for intestinal failure. If you go through just quickly, you will have a broad knowledge of what exactly they mean. The second, I don't want to get into this intestinal failure and causes of intestinal failure. Do you want to go to the next page?
But causes, as I mentioned, it's very easy to remember.
I don't want to get into that now.
Just to give you a recall, anatomical cause, when you don't have enough bowel. A functional loss, it means that it is bypassed by EC fistula. You have a bowel, but it is unable to perform a function. And the loss of absorptive capacity, that can be due to the IBD, celiac disease, radiation enteritis. Or the fourth one is the abnormal functional bowel, which is Ugleev's or the ileus.
Yeah. I also mentioned one thing, going back to the previous slide, the first slide. So in this first slide, when will I recover? I'll also mention to the patient that she's at high risk of having reoperation and further resection because she's had a SMA, probably an SMA catastrophe, isn't it? So she might have to go in and we might have to resect more bowels. So that's all the more reason why will I say that I'll be non-committal when she asks us when will she recover.
Yeah, I thought about that, but except it clearly mentioned she's recovering well, so I assumed we'll leave that for another discussion.
Okay, fourth slide, please. Okay, so I think he answered well. We may, and when we think of anastomosis in the bowel, I will not anastomose by myself. I'll put the patient in MDT. I'll put the patient get the opinion from the IF center. I won't anastomose until they give a go ahead, because this patient may need a lengthening procedure, small bowel lengthening procedure, long bowel lengthening procedure, whatever. So I won't go and anastomose by myself. I will refer the patient to get an opinion from them. And at the most important is, we are not going to anastomose in an immediate future until the patient recovers well, until we are sure that this patient is going to be nutritionally capable of getting this nutrition, getting revived from all this catastrophe. Yeah. Any opinion, difference of opinion in this?
Yeah, I agree. But yes, it should be dealt in a specialized center. But anastomosis will definitely help in the recovery of the patient, because
we can comment that I will anastomose, but before I say that I will anastomose, I will definitely mention I want to get an opinion from the dietitian, ITU, because you are going to subject this patient for another surgery, which may be successful or which may fail, and also we don't have any input from the specialist center.
Because the anastomosis is very important, and emphasis that Gohan put on that is very real, and it should have been put, because what I read in the companion, that the normal healthy colon is equal to the 50 centimeter of the bowel in terms of an absorption of nutrients. So you get
what is the guideline? What my question is, when are you going to anastomose? Is it in the same sitting?
Never.
Absolutely not.
Okay. That is what
send the patient to intestinal failure center.
That is what I'm mentioning. Yeah. I'm mentioning that whether this patient is going to get anastomosis, when are you going to play? So when I want to answer this question, my thought process will be, is the patient fit for anastomosis? If we go for anastomosis, is this patient going to have the bowel without any bowel issues? Is the anastomosis going to take up? Is the intestinal failure team or the specialist center are going to do anything with the bowel which is left out? Are they planning for bowel transplant? Is this patient fit for this anastomosis, re-anastomosis? So all these things will be there in my mind before I think of anastomosis in this patient.
Or just to better verbalize, I will say the patient factor, disease factor, and the complication associated after this surgery.
I agree with the intestinal failure referral, but usually a bowel anastomosis doesn't alter a transplant. So that part, I think, yeah.
I don't know. I don't know. I'm not.
Well, I've managed these patients before, so yeah.
No, I think in a 70-year-old, I don't think she will be given the option of a bowel transplant. That's a 65-year-old with AFib with multiple comorbidities. I don't think so, because she's already an arteriopath, probably, and she's at high risk of developing mesenteric catastrophe even later. But then following up to what Varun said,
in that scenario, are we going to anastomose her earlier?
Well, I think that decision should be left best left with the intestinal failure unit rather than us. And also going back to the second slide, Sakib, the electrolyte, I think the answer to that would be she'll be losing at least 6 liters of fluid, hyponatremia, hypokalemia, hypomagnesemia. But most importantly, it would be metabolic acidosis, because she'll be losing a lot of bicarbonates. And with regards to nutritional, she'll be losing magnesium and phosphate and trace elements also.
Guhan, I think that will be a question regarding thyroid function test and selenium in this patient, because selenium, thyroid, vitamin deficiencies, you can expect all kind of vitamin deficiencies in this patient.
Yeah.
Okay. Sodium will be lost, potassium will be lost, magnesium, calcium will be lost. all the fat-soluble vitamin will be lost. Patient will have increased chances of gallstones. Patient have water-soluble vitamins still can be absorbed, but still patients suffer the problem of the thiamine deficiencies. So these are the problems. Yeah, and beside that, the less absorption of amino acids, glucose, and the triglycerides.
You wanted to say something?
Yeah, I was just thinking at this point, one, in case I suddenly disappear, both my battery and phone battery is going. I wanted to tell Gohan, of course, sorry to be, maybe, I don't know if my comments are a bit harsh, but the approach to the first question, again, I think the crux is that you're talking to the patient. You've explained all the factors more of, say, as a discussion of intestinal failure in a forum. But if that question comes in the exam as to you're explaining to the patient regarding recovery, I think we'll have to summarize it as the cruxes are, like Prashant said, one, a non-committal answer. Two, probably I would tell my patient, you've just recovered, you're on day 5 recovering from a very major operation for a very complex problem, for which the prognosis is usually not good. The fact that you've reached this stage and you've made it to day 5 and you're recovering well is itself good. And looking forward from here, one, we have to look at the immediate complications of the operation. And if at all you're past that stage, then the next stages include your nutritional rehabilitation along with the multidisciplinary team. And I will say, I will refer this case to the intestinal specialist unit and ask them their opinion. And if they want to further manage your case. In my limited opinion of managing these patients, I would say that I can't give you a timeline of when you will recover. And it could be months, it could be years, and it could involve more procedures, it could involve further specialist care. So, and I think that would have to just answer that initial question. And then, of course, the scope of discussion in intestinal failure is limitless. So, and I'm sure you'll be able to manage the rest of it. But I think you get similar scenarios when you say you're asked to consent a patient, or if you're asked to say your patient has a complication and you're talking to the next of kin, or if you were going to discuss it with a colleague. I think the discussion has to be just literally how you do it in that scenario, and rather than the knowledge or the knowledge aspect of it or the theory.
I think Senthil, you have excellently worded that. It's because the actual answer is very small, but it's more, beating around the bush that we have to do for this exam.
Yeah. And the last question, shall we go to the last question? If I'm not wrong, the referral is after 1 year. You try to manage. I think they don't take up the patient that easily in the intestinal failure. Yes, Akib, you wanted to say something?
No, yeah, carry on. Yes.
No, like we manage with TPN, home TPN, get the input from them, dietitians review, make sure that the patient is surviving well without any nutritional problems, monitor the patient on a monthly basis or 15 days basis. I think we have to check their vitamins, thiamine, like especially thiamine and new electrolytes. There's a set protocol for this thing. I don't remember now, but there's a set protocol to monitor the bloods, monitor the nutrients, home TPN, and then I think it's up to 1 year. They have some cutoff time. Okay.
Yeah. So what I would say that once you have removed this segment of bowel, the phases actually depends upon how your bowel will take up, right? And it is divided into 3 phases. One is the patient suffer from a hypersecretory phase that lasts for 2 months, and it is a very quite distressing phase. Most of this phase, the patient spend in their hospital where the first operation was carried out, because they will have a problem of high stoma output, electrolytes imbalances, skin excoriation, stoma management. So this is called a hypersecretory phase. Then from the 2 months to 1 year, it is called an adaptive phase. When with the help of medications and the bowel start taking roles, the bowel generally takes more good role in the neonates and infants and young adults rather than old people, because they can their bowel can adapt more good rather than the old people. Then this phase rests from the 2 months to 1 year. And this is the phase where the people are managed between the hospital nurses, stoma nurses, nutritional nurses, and the home TPN team, right? And after the 1 year, yes, as you have said, that it is a stabilization phase. And then you need to see that what to do, whether the patient should be given an option of transplant or these things. So these are the phases. Now, coming back to this question, National Intestinal Failure Center, a Sandmark is one of the centers, yes. And the criteria is generally based upon numerous factors. One is that if your patient is on requiring a TPN and you think that patient can go home, but all the vascular accesses are exhausted, and then the patient needs some form of an national intestinal failure center. The second thing is that if you are a colorectal surgeon, the guideline says that you have attempted 3 operations for any EC fistulas and if you have failed to manage, you need to send this patient. The third thing is indication is very, very, very straightforward. If you have a complex EC fistulas and almost the abdominal wall, which has multiple dehiscence, and it is just a there is no abdominal wall, then these patients should also be referred to the intestinal failure centers, which is the St. Mark's and also I think one in the Manchester. So these are the 2 intestinal failure center where you should refer this patient, either because the complication of a TPN, or you are unable to maintain a vascular access, or the complex enterocutaneous fistulas. Colorectal surgeon has in their unit have made 3 efforts, unable to settle the problem, and the 4th one is So these are the common
Gohan, as a upper GI, I don't think you need to know all these things.
Yeah, I agree. Just straightforward say that.
But at least what I feel is like you have to have an open conversation, saying that from this scenario, as an upper GI, what I will say is make sure that you open the conversation. As Sendil said, open the conversation. Said this is what has happened. You are right now okay, but we are not sure what will be the prognosis of this for this problem in future. We'll try to get the specialist involved. We'll try to get the colorectal team involved, get the MDT opinion, all these things. We'll let you know what next. So and then when to refer, you can say that this will be discussed. I'll get an opinion, but this will be this will be the approach. That's it.
How about if such scenarios are presented in the start to the colorectal consultant, that I have done an emergency operation, I'm not expert of that, and
ideally ideally if you're a colorectal, even if you're a colorectal, doesn't matter if you're a colorectal upper GI or anything, you have to involve a senior colleague immediately, as early as possible, and if it is a midnight, you get the opinion early in the morning, or if it is in the daytime, get involved, get your colorectal colleague into the theater immediately.
No, my question was that involvement of a colorectal colleague on the first question, that when I will recover and how was the operation.
No, you are going to refer this patient to colorectal MDT.
Yeah,
you're not going to refer the patients directly to the IF center. If am I right, guys?
Yeah, I think we should have mentioned that earlier. I will refer this patient to a colorectal MDT and take it from there. Before we jump on to referring to intestinal failure unit.
Gugan, in a nutshell, as an upper GI, if I'm going to appear for upper GI, what I will say is, this is your recovery time. Now you are the 5th day. We don't know how far you will recover. I'm honest with you. We have removed a whole big chunk of bowel, big, long, lengthy bowel, and the recovery will be. I don't have any clue about the recovery. We'll put the page. We'll discuss your case notes in colorectal meeting. You may need a long-term. You may recover or may not recover. You may need a long-term TPN if you are recovering out, and there will be plenty of nutritional problems because we have taken off all these things. And I'll update you once things move forward on a daily basis or a monthly basis. That's it.
Yeah. And one thing I want to ask is this 30 minutes scenarios. I was just going through the JCI, this thing. 30 minutes where we have the vivas. They had mentioned that 6 questions each, 5 minutes each. What does it mean?
I don't have any clues. Even I felt I had plenty of.
I think 5 minutes for each question, and it will last for 6
So
minutes.
it is like this scenario, like 5 minutes.
Yeah,
scenario.
5 minutes. Yeah, this scenario. Yeah,
then
like
it's
this.
like if they've given like a thyroid case, we can't go through the entire history.
No, I was
No, so as I understand,
I was going through the past question, and I think I just made it in a bigger fashion so that we can discuss a lot of aspect, to be honest. But generally, the 5-minute scenario are very simple. I mean, straight liners, neck swelling, anatomy of the triangle, and that's what it was written. I mean, they will not be expanded to that extent, but it's just to for the sake of a discussion.
Usually how it is one, and it's irrespective of the question, see, because a lot of questions, however simple, also you can have a discussion for 15 minutes.
Yeah.
It is up to you to ensure that you get all those 6 questions. It is in a way that one, you can have a dangerous examiner who sits and listens to you for one question for half an hour, and you are marked on one question, and you will get, even if you get full marks for that one question, you lose your chance to answer the next 5.
Yeah.
So the onus is on you to make sure roughly that you utilize, either you don't know anything in one question and you pass it, it doesn't matter. You can take it, you can come back to it if you still have time at the end of 30 minutes and you answered 5 questions, and you can say, or sometimes the examiner can say that, do you want to, go back to answering this question?
Yeah.
So, but the onus is on you to try and get more, at least attempt all the questions.
Okay.
So if you answered a bit, sorry?
It will be like 6 scenarios then. Each 6 scenarios, each 5 minutes.
Yes. It could be based on one topic and multiple questions based on that, or it could be multiple. That I'm not sure. But usually what will happen is each 5-minute segment will be treated as an individual segment.
Okay.
So it will either if you answered it quickly and it's a short topic and the examiner is happy you've covered all his points. Basically, these examiners have a checklist of points, and as soon as you answer that one point, they just tick that on their answer sheet. That's what I've been told. And the instant they feel you've gone through all of it, they themselves will say, okay, next question. And so you may answer the 5 minutes, you may answer in 2 minutes, and you have an extra 3 minutes on the next question. Or you may take 8 minutes, unfortunately, and lose out 3 minutes on the next question.
Yeah.
But the onus is on you to try and get 6 questions in that setting, and that will ensure you pass 100%. I guarantee you. The only time you fail is when you say you've done only 2 questions in a 30-minute session, then that's finished.
Yeah.
Guhan, what did you say about the each question?
So this one sorry, are you asking me?
Yeah, no, Senthil, what was he saying about each question? Each question is each scenario, or is just one question?
That's what I said. So if you have, say, a 30-minute session with 6 questions of 5 minutes each question will be scored as a unit.
Okay.
So that 5 minutes for that one question will be scored. So you will be scored on marks into 6. So basically what I'm saying is, if you answer only one question for 30 minutes, you will get only, if that one question is only 5 marks, you will only get 5 marks. You're not going to get 30.
Yeah, but is that actually just a question, or is that a scenario?
Usually, see, in the Viva, there will be 6 scenarios.
Yeah.
Each scenario is 5 minutes.
Yeah, exactly. So it's not a question.
Yeah. So
no, it's a scenario. Not a question.
Not a question. So within that scenario, ideally they say you have to cross 3 to 4 questions at least.
Yeah.
So that's what I was asking. Like, you get a thyroid swelling, and they just tell you that there is a neck swelling, and
it's quite difficult one to see. Sometimes they may give us more history and all those things.
Okay.
But a few things which I picked up from this course is I think the examiners, I don't know if they're UK examiners, they don't like to interrupt. Okay. So you need to stop talking.
Okay.
So you can stop talking, especially in the 5-minute thing.
Okay.
So you need to say. So you say that for staging, I'll do a CT, MRI, and see for the purpose of adequate staging and planning. Then if you stop, then they will show you the images. If you say that this is and all, then they're still waiting for you to stop.
Okay. So ideally in the 5-minute scenarios, we need to be on point and.
Yeah, I don't know. So yeah, they say you need to converse like a colleague. This is not a MRCS and all those things. But,
No,
but again,
I was just wondering, like, if you tell a thyroid swelling, you can speak about the history for history and
Yeah.
No, that
examination.
is what
Fine.
that's what. See, as Senthil said, as things are like, if you're going to talk about thyroid, don't just get a focused history on pressure symptoms, malignancy, metastatic symptoms,
Okay.
hypothyroid, parathyroid, hypoparathyroid, or if it is breast, I'll check into the nipple discharge, types of nipple discharge, duration of the swell, duration of the lump, any axillary lump, any history regarding the pregnancy, breastfeeding, OCPs. So all these things. I won't go into in depth with the history if it is a 6 minute or 5 minute scenario.
Yeah.
So the most difficult part is, everyone says the most difficult part is you crossing this history part. But sometimes, like in the February exam for my colleague, what this was, you are in the clinic, you have done a PR, you're seeing a mass on the digital rectal examination. So you take the station from there.
Okay.
So he tried to say that I will take the history. Then he stopped him. He stopped him and said, "Look, you have taken everything. You are doing a PR now. You tell me from here." So,
okay.
And then
So that is what I think. Somewhere we discussed about some ITU scenario. The patient is in ITU. What next? We were discussing something like, so what next? When I yesterday, I think I discussed with you. So ITU. So my approach will be, the patient is already in ITU. My questions will be, how far the patient is in ITU, how many days of paracetamol poisoning, how many days of failure, how long you are managing her in ITU, what question do you want me to answer from your point of view. So I'll start from there, so that the history and things gets less important rather than taking forward from that point. Prashant?
Yeah, I agree, because when it's an ITU patient, all that we need to say is, I'll check the patient's note and take a brief history from the ITU, treating ITU intensivist, and get relevant history from there, and progress on to examine the patient. And in history, all that we need to say is just the positive, what you want to find, or what you think that station is about. I wouldn't go banging about taking an extensive history or examination, because in an ITU patient, you have already even been given the findings. Because the more time we waste on history and examination, the more we'll lose out.
Yeah. How was the day, Akshay, today? Were you okay?
It was excellent. It was really good. I think it was really good. Yeah. Thank
you. Don't take it in a different way. The thing is, this is a practice for you. I think even for Akshay, we will know. We can know how to approach when the same things approaches. The most important thing is talking to patient. That is what we miss actually. What I learned after coming to UK is, talk more. The patients are more comfortable when you talk more than do less. They're happy with whatever we do, but only thing is, they wanted to communicate whatever we do. That's more important.
Yeah, I completely agree, and I have to reinforce now and then that I am upper GI surgeon.
Yeah. Don't think about transplant. Don't think about
so much.
Arterial anastomosis, bile duct anastomosis, left hepatic duct, common hepatic duct. Just forget about all these things and come to chylothorax, pneumothorax, hemothorax, putting a chest drain.
I think Juan and Akshay did extremely well. Really nicely prepared, guys.
Thank you.
Thank you.
Prashant, you are appearing for upper GI?
Yeah, I'm appearing for upper GI, but it doesn't look like I might clear this time. So let's see. It would be a good experience.
You'll definitely clear. I know that.
The scenario was easy, but you were
perfect.
No. It was perfect because it was cholecystitis, but otherwise I haven't prepared much about other topics. I just came back from retrieval today morning, and again I might have to go back tonight, so it's fine.
Oh.
One thing again from this web cross course, see what I learned is many of this UK trainees they were in the Viva sessions, they hardly knew anything, but they never stopped talking. Like but when they asked me a question and I didn't know, I sort of stopped talking. I was thinking, but
So that
they're
is
like,
what
oh
you
well,
have
we
to.
can do this, we can do that, we'll see.
Yeah,
I
that is
think
what I wanted to say. Go and that is
to
what
try and
like
make a conversation.
it is not the conversation of your knowledge. It is
Yeah.
the conversation of your approach
Yeah.
in that scenario.
Yeah.
What you will do and how many people you are going to involve in your
Yeah.
management.
Completely
Yeah.
agree.
It is not the knowledge. This caused this. This caused this, and this is what going to happen. That is a and they are much as a patient. I'm much more interested about how long I'm going to live after this. So that those are the things are more important than how much of bowel is left out. This will cause this deficiency. This will cause this deficiency, and all those things. So when we talk, the question if the question is what are you going to say to the patient, I'll say this patient, as a patient, you will have this problem in the layman term rather than using some medical jargons. Literally, we literally the patient will not understand whatever we say.
Yeah, most of the many of the scenarios will be like the examiners will say, oh, "Look, I'm the patient. Take a consent from me." So then you need to say, "Oh, hello, how are you? I'm so and so. I'm your consultant in this thing," and you get so like that. So see, it is very difficult to say in 5 minutes what to say and all those things, but it's fine, I think. Yeah.
You guys are escaping. We guys will be with the patient.
That is the.
I'll join you. I'll join you for September.
No, Prashant, I don't think so. you guys are going to give us a good feedback. These are the things which happen. Please be prepared for things.
Okay, guys. Thank you for.
All right. Shall we wind off?
Yeah.
Thank you very much.
Thank you.
Thank you.
We'll give a gap. I think we have to let them read Sakib.
Yeah. Thank you, Sakib.
Yeah, absolutely fine. Yeah, no problem. Okay. Let me
I'll have go on, Akshay, Prashant. Do you want any more thing or?
Yesterday.
Endocrinology. Do you want to practice endocrinology? Neck swellings.
Yeah. Let's do endocrinology next one.
Okay.
Yeah.
Okay.
Breast and endocrine.
Breast and endocrine done.
But I don't think being upper GI or colorectal will be asked too much about breast cancers and all of that, is it?
I've got a breast person who said me that he'll join today or sometime this week.
Can breast be asked in the general surgery Vivas? Is it possible?
Breast abscess, huh?
Breast abscess is fine. Breast cancer can come as well. I think the practice that we need to adapt is that doing everything by ourselves. This is the tendency that we have.
No, I've got one person. I spoke to one person who's a breast essays doctor who completed FRCS, and he said he agreed to come in, but the thing is, he said that he'll be it'll be on Sunday.
No, I'm not talking about that. I'm talking about on the scenario management. We have a tendency, like if thyroid comes in, we'll say that I will operate, I will do.
No. I won't do it. I changed
the breast as well.
I knows about me.
I would do this. And I think if we conduct a practice session, then we will have a better idea. What is our approach? How far we need to go? And when is the best time to refer it to breast surgeon to do an operation? And when is the best time to refer it to endocrinologist to do an operation?
Yeah.
Anyhow, we'll do it tomorrow. When do you want, Goan? Akshay and Goan, when do you want? Prashant?
Not tomorrow.
Wednesday or Thursday, whenever.
Thursday is fine.
Wednesday I won't be able. Sorry, guys. Wednesday I'm off. Thursday I'm happy.
Thursday.
Okay.
And Dr. Amar had told that we'll discuss these rare questions and.
I don't know. He said that he's on call, isn't it?
Yeah.
I'll
we have
check
it
with
like weekend because that's like a very important thing.
No. When is your exam?
It's on next Thursday. So sometime before that, be fine.
Are you happy on Sunday? We'll make a full day session on Sunday.
Of course.
I'm free on Sunday, so we'll do it on Sunday.
Yeah, sure.
I'll make sure that all these people are in the Zoom on Sunday. We'll get everyone involved.
Yeah.
So Varun, you are expert in breast. Can you make scenarios from breast?
Yeah, I can make I can make scenarios in breast.
I will cover endocrinology and you cover the breast. Okay.
Have we done critical care, general surgery, and all of that, applied anatomy or anything?
No.
I've got few scenarios, Prashant.
No?
I made few scenarios. The thing is, even if we stick on to 10 minutes and 20 minutes issue, still we run over time with the discussion and people's opinion.
No. Let's do like actually 10 minutes, and we can go ahead. And I don't know whether we have covered HPB. Have we?
Yesterday we did some bit of HPB in the sense.
So let's do it. Thursday, endocrinology and breast, and the Friday we can do some stuff in general surgery, and then we can use
Friday, Saturday. I'm not available, guys. I'm sorry. Yeah, but I can give you the link. You guys can do it.
Yeah. I think that is also important. Critical care, general surgery, and all of that. Emergency. Emergency is fine. I think so. I think all of us have done, but it's more of the general surgery.
I agree.
Prashant, go and just text us what are the things which you guys need, and then we can make some scenarios.
Critical care would be fine, and as you told, endocrine and breast we can do. And very important is the rare
go and I'll ask Amar to join on Sunday. Okay, Amar and few other people. The few people have agreed, but they don't want it on the working days.
Okay, sure.
That's fine. Endocrine and breast is confirmed for Thursday.
Shall we wind off?
Yeah.
Sure.
Thank you, Varun. Thank you, Saqib. Thank you, everyone.
Thank you. Bye.